We've got quite a lot to go through, so I'm going to kind of dive into what we need to talk about today, so that we can give enough time for question and answer. Suicide is pretty a hot topic, uh, where some of us avoid, some of us have had bad experiences in our practice, and we're going to be looking at what is the current data we have and look at how to manage issues related to suicide that may come across our way. Just to check out, if you want to send questions, Kathleen is taking the questions in the chat box. So if you drop your questions in there, I would try as much as possible to give enough time for questions and answer afterwards. So as Kathleen mentioned, part of what I also do apart from my work in adult psychiatry is forensic and child adolescents, and I also do some bit of medical legal work in addictions and psychiatry. So next slide, please. So let's kind of look at why I chose this topic. In actual fact, I was going to talk about anxiety and depression, and then I changed this to suicide when I read a report that was published. I'm not sure if some of us have read the report. This was a research that was done through CMPA. It was published in May of 2025. And what they looked at was CMPA reports for doctors between 2013 and 2023 involving suicide attempt or completed attempt. What they looked at was they've identified 378 cases were identified, and it involved 460 physicians. Now let's look at the number: 378 cases, but 460 physicians. That means that the suicide risk or the legal claim or the medical legal issue that was identified goes beyond the primary physician. So that means that we all have a part to play. Now, out of those 378 cases that were identified, as expected, psychiatrists were involved about 61%. So 231 of the cases were involved psychiatrists. Now, this is also interesting because the remaining 40% most likely involved other professionals that are not psychiatrists and would definitely include primary care physicians. And this is why this topic is so important and dear to my heart. Now, looking at the most common concern that was raised in this complaint or this medical legal issue that was brought up, there were three things that stood out. Now, number one is that patient and family they were deficient in assessments. That's number one. The second thing was that there was diagnostic error. And the third one is breakdown in communication. Those are the three key areas that were identified in terms of, and also the obvious one, which is now. So that is from the patients, from the complainant. Now, when we had a peer review of the chart, which is expected when there's a CMPA complaint or medical legal issue, what they identified was inadequate documentation. So deficits in assessments and inadequate communication were identified by the peers that reviewed the charts when there was a medical legal claim. And this is very important, and that is what we're going to be looking at and talking about today. So the next slide, please. Before we go ahead into talking about management, let's actually look at what are the data we have out there. This most likely will not be news to some of us who are in the field and into a lot of research. So as we can see, there is 12 people dying from suicide daily in Canada. And it is known to be the leading cause of death, especially for young people. Now, when we say 12 people dying a day, sometimes let's take it home. Some of us have been working from 8 o'clock or from 6 o'clock. That means that for the time we've been working from 8 o'clock till now, there has been 12 people or more, or 12 people that have died from suicide. So that is one person per hour of 12 hours that we work. And there's a strong link, as expected, between mental illness and suicide, up to about 90%. And most importantly, what we found out is that, and this is from Statistics Canada, what we also found out is that most people that have committed suicide, they had contact with healthcare providers before they died, for primary care physician in the last 1 year. That was what the data showed us. Now, let's look into more data set of these high-risk groups that we're talking about. And the importance of high-risk group is so that it helps us to know what to do when we come across this set of people, and also guide us in our risk assessment and management, which is the most important thing in itself, in terms of what we're trying to do today. So we know that between the ages of 15 and 34, suicide is the second leading cause of death. Between men that are over 45, it is the highest absolute cause of death, and it increases when men are over 70. Now, let's come back home to BC, and tomorrow is Truth and Reconciliation Day. Unfortunately, we have about 2 to 3 increase in Indigenous people committing suicide compared to the general population. When we look at our population in terms of suicide in BC, it is not far from what is obtained nationally. But when we look at Indigenous population, unfortunately, we have a 2 to 3 increase of suicide in this population. And there's a vast variety of reasons for this. And this is why we have to take this group of people seriously, and also look into provisions and care we offer to them. Now, when we look at men, like I said, men are at a higher risk. In Canada, 3 out of 4 men complete suicide. And it is often by little means, mostly gun, especially gun. Now, women, unfortunately, they have a higher attempt and hospitalization compared to men. Now, the other factors that we have is that in some immigrants, one of the things we found out is that first-generational immigrants, there seems to be a protective factor. The suicide risk is not as high than general population. But in the second generation of immigrants, we see a higher number of suicide in this group of people. And same thing goes with refugee. Now, for socially isolated people, we also notice a higher risk. Now, why are these data important? Now, like I said earlier on, most people that committed suicide, they've had contact with a primary physician in the last 1 year before they died. Therefore, our clinic is ground zero. That is the basis, and we're pivotal in the intervention, prevention, and management of patients with suicide. Next slide, please. Now, like I said earlier on, we've talked about these status already. Most of the cause in Canada is there are 3 common causes of suicide in Canada: hanging, poison, and firearm. Hanging, strangulation, and this one consists to be the leading cause, and it's about roughly 50%. Poison is about 25%, and firearms is about 12%. But if you have a look at it, firearm is more common in men, right? Males are more likely to use firearm and hanging, whereas female use poisoning, although some firearms, some hanging are also noticed in female, but mostly it is poison and hanging. And this is why what we call environmental modification is important, and we're going to talk about those later. There is preventive measures which can be psychosocial, and there's also pharmacological or biological methods of managing and minimizing risk relating to suicide. Next slide, please. Let's look at what we call risk factors. Grossly, or kind of as an overview, I tend to categorize risk factors into 2, and one of them is called modifiable risk factors, and the other is statistical risk factors. Now, statistical risk factors are unfortunately not modifiable. And as expected, they include previous history of suicide attempt. Interestingly, that is the single strongest predictor of another attempt. That is why it's important for us to ask our patients, have you committed suicide before? Family history of mental illness and suicide is also an important factor. That is why in psychiatric assessment, we do ask if there's a family history of suicide. As mentioned earlier, male sex and older people. And older people, that's where isolation ties into increasing the risk of suicide. Now, historical childhood trauma, which we call adverse childhood experience, has been known to be a statistical risk factor, and this probably will be more pronounced in immigrants, in refugees, and also in indigenous population. Now, the good news is this: there are modifiable risk factors. For example, chronic mental illness that can be treated, substance use that can be screened and referred. Now, there's also severe hopelessness and anhedonia that can be treated and addressed. Modifiable risk factor include accessible to weapon. For example, we know that there is, in terms of, in the past, when you use gas poisoning for suicide, this has been changed where you can't use the gas from your exhaust to actually commit suicide. Unfortunately, a lot of people don't know, but the risk of you gassing yourself to death is reduced because there are things that have been put into the cars that reduces the emission of carbon monoxide. So those are things that have been done to reduce means and access to completing suicide. The other modifiable risk factor includes social determinants, like we mentioned, the age, young adults. There is another population which I forgot to mention, the LGBTQ. We have also noticed that there's increase in risk of suicide in this particular population as well. And there are modifiable risk factors that we can treat or modify to minimize, reduce, or eliminate risk in this population. Next slide, please. Now, so when we talk about risk and risk assessment, there's a 5-minute triage. I know that we're very, very busy physicians in family care. We see quite a number of patients, but it is also important for us to notice that there are some times when we have to go a bit further, where we have to take that 5-minute triage and ask key questions. It's going to come up later in the slide, but I want to mention it here that asking about suicide does not automatically lead to increase in suicide. Asking about suicide does not lead to increase in suicide attempt. So we have the low acuity when they have the passive suicidal ideation. It's not, I just feel like there's a feeling, there's no plan, there's no intention. They have very strong support. They are able to collaborate with you, right? So in those kind of patients, the key thing to do is a safety plan, reduce MACE. So ask about firearm, ask about medication. You know, one of the modifiable risk factor is that when you know that a patient persistently takes overdose of prescribed medication, one of the ways you can do is to do daily dispensing. You can do weekly dispensing to minimize access to means of completing suicide. And then the most important is follow-up, which I will talk about later. Now, for moderate acuity, when there's a specific plan, but they are ambivalent about it, there's significant hopelessness when they start to say, what's the point? Right? There's anxiety. They start to, there's strong impulsive behavior like substance use. Those kind of patients must not be left alone. Those are the patients you, in actual fact, might want to certify and send to hospital for further assessment, where you need to request for urgent psychiatric assessment for, and patient needs to be seen quickly. Now, the ones that are high acuity, those that have a plan, they have intent. There's an attempt in progress. Sometimes it might be that a relative calls to say, look, he's bought a rope, he's giving his belongings away. Now, those ones, the key thing is to activate 911 straight away and direct transfer to the emergency room. There's no two-way about that. Now, the ones we can hold on to in the community are the low acuity. And even with that, I'll still recommend a referral to find out, what am I treating? What is the diagnosis? But while we're waiting for an assessment by a specialist, we are constantly in contact with the patient, following them up, and we're going to talk about management of those conditions in those patients. Next slide, please. Now, there are some questions that we need to ask our patients, and they are categorized into 4, and they go into the ideation, thoughts, plan, intention, and of course, lastly, history. And they're very simple questions. Have you had thoughts of ending your life? Those are ideations. Do you have a plan? Do you have a means? Have you started thinking about it? Now, those are the plans and means questions. And then, of course, on the other part is the rating scale. In terms of 0 to 10, 0 means there's no intention. 10 is that, you know what, right now I'm going to do it. How would you rate your intent? And lastly, do you have history of attempted suicide in the past? Now, those are the questions we can ask, and they are must-ask questions. Have you had thoughts to end your life? It's a must and direct question that must be asked in a calm and supportive way. There's no need to beat around the bush. I don't. When I ask my patients, I ask them, have you had thoughts of ending your life before? And then we can then add more questions from those to help us. Now, a key question, when we did from based on research, one of the most important predictors of suicide is expression of hopelessness. Hopelessness is a key factor. If a patient tells me I'm suicidal and I'm hopeless, I'm admitting the patient to hospital. Because if there's no hope, there's no sustenance of life anymore. Now, there are other things that we can look at. We call them the triad, right? And it is anxiety, agitation, and severe insomnia. There are also other life issues that we're going to talk about. Let's go on to the next slide. So, recognizing early warning signs, right? For example, when they start to say, what's the point? Like I said, hopelessness, recent personal crisis, loss of job, relationship issues, health problems, giving away possessions, sudden improvement. We need to be careful about that. When somebody who was suicidal before says everything is fine, everything is not fine. They just want to tell you what you want to hear. You need to ask, what has changed to make everything fine? If they can't answer the question, it is high risk. Because what they're doing is they are trying to, they have a perception that they're a burden to other people. And because of that, they want to shush everybody off. And in those cases, you have to be asking yourself, do I really believe what he's saying? For example, a 50-year-old man who lost his job, his wife left him, he lives alone. The previous week, he came and said, I'm suicidal. He is depressed. He's on antidepressant medication. He told you about giving his things away. And then he came a week after and said, you know what, doc, I'm very okay now. Everything is fine. That is a red flag. Because everything is not fine. That is what we call the calm before the storm. There's also something that we've noticed in elderly people. This is actually more in elderly people where they test. So self-harm in elderly must be taken very, very seriously. Because in elderly that has no history of self-harm or suicide, before they actually carry out the act, we found out that sometimes they do what is called testing, where they self-harm to see before the actual act itself. This is the reverse of what you find in adolescents. So in adults, especially elderly, when they come in with self-harm, it must be taken seriously as if there is an intention. The other part is the contact of people. Do you have people around you? We've noticed that social support is very key and important in suicide management and prevention. So those are the steps we can use. Recognizing the early warning signs. What are your coping strategies? Do you have any distracting techniques we can use? Do you have a support system? Do you have any social distraction? Do you live alone? Do you have contacts? Do you know how to contact the crisis line? Like all those things, and making the environment safe, like I said earlier on. Making the environment safe, I'm going to talk about that a bit more. One of the things we can do when we're prescribing for patients that are high risk, especially what we find in borderline, that could end up committing suicide as a virtue of misadventure, apart from other things, is we can do weekly dispensing of medication or daily dispensing of medication to reduce the means. If they're living with someone, for example, if it's a child or a minor, one of the ways in which you can reduce self-harm by cutting is there is lock on cupboards where there is knives or sharps. The other thing that has been done, which I've done in some very serious cases, is that we've actually contacted local pharmacists not to dispense Tylenol to some patients, just to minimize access to means. For men, there is nothing wrong in asking, do you have a weapon? Do you have a gun? And ask them the direct question. Do you want to give it to somebody else to keep for you? Those are questions we can use, or those are the ways in which we can minimize risk of suicide by reducing the means. Next slide, please. I've actually started talking about this already in terms of keeping weapons safe, storing it in outside of the home. And if there is a partner, it is important to involve relatives, partners in management of suicidal patients. Another importance and use of family members, especially those that sometimes accidentally overdose, because if for medication sometimes, is to find a trusted family member that can hold on to their medication and give it to them on a daily basis. That way, we are reducing the access they have to legal means of committing suicide. Next slide, please. The most modifiable risk factor in management of suicide is treat underlying mental illness. Referral to psychiatrists urgently, initiating medication while they wait for a psychiatric consultation. So if there is signs and symptoms of depression, which PHQ-9 can pick up, if PHQ-9 picks up suicide, those kind of patients must be started on medication. That should trigger further questioning to ask about the suicide, because PHQ-9 does pick up suicidal ideations as well. And we need to have a management plan for suicide. Remember that in the research that was done with the 378 cases I mentioned with CMPA, one of the things that the peer noticed, the two things was that there was inadequate planning and there was inadequate assessment. Those are the two key things. And it is important for us to make sure that whenever we do our risk assessment for our patients for suicide, we address those two factors. Now, I mentioned the triad of agitation, insomnia, and medical emergencies. The key thing to do is, while they're waiting, if there's low risk that can be managed in the community under our care, while they wait for specialist input, is to treat the insomnia and treat the modifiable risk factors. The agitation, we can use low-dose trazodone, mirtazapine, or sedating antipsychotic medication can be used if it is warranted. But the key thing is referral to specialist services for definitive diagnostic clarification and appropriate treatment initiation. Let us remember that one of the things that was noticed in the report was misdiagnosis. So it's important for us to put that in place. Now, talking about psychological intervention in the next slide, there are things we can put in place to help our patients that have suicidal ideations or feelings or thoughts. one of the things we need to look at is called safety plan. Now, safety plan is not contract. There are two different things. Safety plan is what are your triggers? What are your risk factors? Who is around at home? How can we support you if things get out of hand? Those are the safety plan. Now, if a patient is not able to agree to safety plan, in my opinion, it is a red flag because things can change within seconds. Where someone who is initially rated as low risk automatically changes into medium or even high risk based on adverse life events that may occur between our appointments. So a safety plan is what is going to help us that we have put adequate measures and plan in place to support those patients while we wait for assessment. And if we feel that they are not, the acuity is not severe enough for them to be transferred to emergency room or to request for an urgent psychiatrist assessment. The other thing is that there is the warm hand off. Now, what does that mean? When we see a patient who is suicidal, one of the key ways in which we can build hope in them is to offer them another appointment there and then. For example, you know what? I'm going to see you in about 3 or 4 days' time, or in a week's time, or in 2 weeks' time to see how you're getting on. If you need to call me, call my office or call the emergency services or this, highlighting support services that they can utilize in the community. Now, that has been known to be effective because they feel listened to. So these are little psychological intervention. And sometimes what the patient just wants is just to ventilate. Now, that is what we call supportive therapy, where we just let them just talk about their issues, about their concerns, and we just have an empathic listening. Now, that is a big ask in a busy primary care clinic where you have patients back to back. But it's something that we can do. I mean, one of the things we can do is that you could ask the patient to either wait, or if you can't, one of the default I say is refer the patient on. We're lucky in Langley, we have the acute home treatment team. If you have any concerns and you think, you know what, you're low risk, but I'm not too sure, refer to acute home treatment team for follow-up. They will be able to follow up the patient much more closely. Being aware of resources available to us in the community for those support is key and important. Now, the other part is the social intervention. Now, we've talked about the biological intervention, which is management of any underlying mental illness. We've talked about the psychological support, which is supportive therapy, and also giving them a listening ear and giving them some practical problem-solving skills. Right? Now, the other part is the social support, right? Where we look at who is the social network. Do you have friends? Do you have family? Do you have siblings? Who is around? We must screen for social isolation. It is a significant factor that leads to suicide. And also screen for financial stress. Now, we don't necessarily have to solve the financial stress issue, but one of the things our patients would appreciate is when they know that we take them seriously and we are referring them or giving them resources that they can connect with to help them with their social issues. For example, LCSS, Langley Community Society, is a very good resource that we can refer patients to, especially women and those that have children that are struggling. The other thing we can also look into is that for the indigenous population, there is the Lower Mainland Indigenous Society that we can refer them to for support, and they can give culturally acceptable or specific services to help to keep them to minimize the risk of suicide. Now, let's go to the next slide. As mentioned earlier, Our relationship to our patient is the most important screening tool we have. Now, why is it the most important for us as primary physician? We have longest contact with these patients, apart from the ones that are coming onto our caseload as new patients. We know them for years. We know when things are not going well. So our relationship with them is the most important. And like I said earlier on, asking about suicide does not lead to plan or does not plant an idea into patient's head. In actual fact, it is known to be protective. And that could be the only opportunity or avenue we have to address and mitigate risk of completed suicide. Next slide, please. As mentioned earlier, our role is to triage patients and initialize stabilization. We are not expected to do this alone. That is one of the things I want to mention here. We're supposed to do it in a collaborative way with relatives, with other healthcare professionals, and target pharmacological treatment to address core symptoms. For example, somebody who is depressed, to start antidepressants. Somebody who is psychotic, to start medication. One of the key things I forgot to mention in psychosis is suicide is high in adolescents and young adults who have been diagnosed with psychosis. So when a patient with psychosis has been treated, all is not yet well. Because after the psychosis is treated, there are two things that happens, especially patients that have been diagnosed with schizophrenia. Sometimes they go into what we call post-psychosis depression. The other part is, let me give a scenario of a young boy who is in his second year, an A-grade student, and in his third year, he developed his first episode of psychosis. He couldn't complete his third year of school. He left school. He tried again to get back into university. And these are not cases that I'm picking out of the air. These are cases that I have seen working in the early psychosis intervention program. Tried to go back into school for the third year, the second year to do his third year, to complete his third year. He couldn't because of decline in functionality. He stayed in third year for 3 years. Now, that is what we call downward social trend in patients with psychosis. Those patients are high risk of suicide because they feel, what's the point? Because they are very intelligent. They have become psychotic. They know that psychosis is a severe and enduring mental illness with relapse and remitting nature. And don't forget that this patient has tried to go back into school and failed. It leads to hopelessness and increases the risk of completed suicide in this age group. Next slide. Now, like I said earlier on, it is very important for us to refer and also important for us to offer follow-up and appointment to build hope and connect with our patient. It is known to actually be an antidote to despair, which is a risk factor to suicide. When it comes to suicide, we all have a role to play. We have one way or the other been affected by either a patient or somebody that has been cared for committing suicide. We can work together to minimize the risk of suicide by addressing modifiable risk factors, minimizing risk, offering psychosocial support in the community through primary care system, and collaborative working with specialists, including psychiatrists. One key factor that I mentioned, I'm going to mention that again, that increases suicide independent of mental illness is pain. When a patient has chronic pain or acute on chronic pain, we need to ask, especially when there's significant impairment in functionality, or when there is what we call life-modifying incident like accident or trauma. where somebody who's able to function at a high level cannot function at a high level anymore. Those are risk factors that we need to watch out for. Just as a closing, to let us know that in mood disorder, there's about 2 to 6% of patients that commit suicide based on diagnosis. Schizophrenia is about 5 to 10%, and substance use is about 3 to 5%. The use of illicit substance has increased suicide in this group of patients. And sometimes assessment can be tricky where you don't know, is it accidental overdose or is it intentional overdose? Next slide. Thank you so much, everyone. I'm now open for questions, comments, or answers. Should we go through the chat box to read out the questions first and then?
So we have one from Nav. Is there a universal tool that you would recommend to use? And she has an example of personas.
Yes, so it depends. There are various tools that can be used for suicide assessment. In primary care, it's more difficult because of the fast-paced nature of primary care setting. That's why I haven't brought up any tools to use. One of the key things that I said earlier on is ask about hopelessness. And those 3 items I mentioned, which is number 1, do you have any thoughts? Do you have any means? Do you have any intention or plan? That is a basic risk assessment tool that we can all use and is easily available for us to use. Just those 4 questions. They are actually what we will find in other risk assessments. So they are key questions and they address key things like feelings, thoughts, plans, intention. And of course, have you attempted suicide before, which is history. Those 4 questions are easy to do within primary care settings, can be done within 2 minutes, and you have the answer you need to be able to say, hang on, I'm worried about you, I'm going to refer you. I can see you again in a week's time, or in actual fact, stay in the office or stay in the reception. You need to go to emergency room right now. Also, just to mention, there is a study in 2017 or 16 thereabout by the Royal College of Psychiatrists in the UK, and they've actually mentioned, and I think it's also by the NICE guideline, they've talked about the futility of risk assessment tools. Now, I'm not saying we shouldn't use it, but there is some evidence that risk assessment tool in itself does not capture the actual people who are at risk as compared to building rapport. Now, somebody who is suicidal and we're asking, are you going to kill yourself? And we're ticking off boxes. They're going to just answer questions the way they want because we have not developed that rapport. So I prefer risk assessment tools being used in a collaborative way that ensures rapport between the patient as compared to a tick box.
And then continuing with the hopelessness piece, is there a specific way to assess hopelessness, or do you just ask them directly if they're feeling hopeless?
One of the key things I start off is I ask the patient, what's your future plan? That's a very basic question because hope is for the future. I ask, what's your future plan? Do you have any future plans? If they say, you know what, I'm just living the day as it comes. I then go on to ask, any feelings of hopelessness? I ask them direct questions. So there are 3 questions I ask, which are what we call the psychological symptoms of depression: worthlessness, helplessness, hopelessness, unfounded guilt feelings, where somebody just feels guilty for mundane things. I've had a patient feeling guilty because it's raining. You don't control the weather. But because of the severity of their depression, they feel guilty for everything. So out of those psychological symptoms, the most worrying one for me is when a patient expresses significant despair and hopelessness. where there's no desire for future or there's no desire for living. Now, the second one to that is helplessness. When a patient feels that, you know what, there's no help for me, what's the point? So those two questions, but hopelessness is the most worrying one, or the most indicative of suicide amongst those four questions.
And then there's a question about follow-up appointments with the psychiatrists. So we know that the Langley Mental Wellness Clinic through the division is just mild to moderate. So would those follow-up appointments be more with the Langley Mental Health Center through Fraser Health?
Yes, absolutely. So if there's a patient that I see in clinic and they are suicidal, and now we have to separate the historical ones, but active suicidal patients, if I'm seeing them in the wellness clinic, I'm sending them to the emergency room. And I've sent some patients to the emergency room before. I've also sent patients to the acute home treatment team before, where I think they need constant follow-up. And if they are complex, for example, they have historical risk factor, diagnosis of borderline personality disorder, anxiety, depression, passive chronic feelings of not wanting to be around, they are not urgent. I recommend referral to the mental health center for ongoing monitoring. Those kind of patients, because of their complexity, they do need a team-based approach of care. So they won't be suitable to be held within the primary care setting. There are some times when those patients are discharged back to the care of family doctors. When we say that this risk is their baseline, this patient has been feeling suicidal for the past 25 years, there has been no change. Now, if those patients are referred back to us, what we need to do is to note that baseline. What we're looking for that will prompt a referral is when there's an increase in the baseline. Somebody who says that I'm feeling suicidal is not saying that, you know what, I think it's just time. That's a change in baseline. Those should warrant us digging further and asking more questions. And if need be, refer back to mental health services or actually sending them to the emergency room for further assessments. I hope that answers the question.
Thank you. Now here's my pronunciation might be off, but can you, Dr. Lajitan, speak to your perspective with differentiating and managing expressed suicidal ideation that might be hyperbolic, example, borderline, or histrionic?
First of all suicidal expression must be taken seriously. That's the baseline. If after we've assessed, and they are, like I said, they are what we call baseline, this is their baseline. For example, you could have a patient who is psychotic and they continue to hear voices. It's not distressing, it's not impacting their functionality. They just continue to hear voice. That's their baseline. They're stable on medication. The risk is not worsening. Let's translate that into suicide. So if you have a patient who is borderline, baseline, but functioning, there's no issue, there's no plan, there's no intention. They just have feelings of not wanting to be around or even constant thoughts. But they say that, oh, I just have the thoughts. I've never harmed myself in years. Those kind of patients, the next step, remember we said that one of the key things that the peers have picked up is inadequate risk management plan. Those kind of patients who are low risk, the next thing we need to do is, what is the contingency plan? If things get worse, do you know what to do? And we document it. Patients are aware of factors that can escalate risk, which are A, B, C, D, E, F. Patient is aware of risk management plan, which include go to the emergency room, call my office, call the mental health center. Those are risk mitigating factors. Once we document those, even if an eventuality happens, at least we have done the due diligence we're supposed to mitigate those risks. The other thing we can do for those patients is frequent follow-up. When the patient knows that I'm having contact with my doctor regularly, there's a way it is. A lot of times as physicians, there's something we try to do. We want to treat, we want to solve problem. We want to treat, we want symptoms to be eradicated. But in some instance, recovery does not mean resolution of symptoms. Recovery could be functionality. There's this, you still continue to express suicidal ideation, but there's no plan, there's no intention, there's no action. Right? That could be their baseline, and all we can do is offer them supportive therapy with regular follow-up. Those kind of patients, though, when they start to miss appointments, it should be a trigger for us. Now, why is she missing appointments? Now, in those kind of cases, my opinion would be to request for a wellness check on those patients. I'm not sure if that answers the question, or if there's a follow-up on that.
Was that enough answer for you, Jeff?
Yeah, that's fantastic. Thank you.
Awesome. And then Dr. Lajatan, there's one more question, but I don't know if this is a you question or a maternity clinic question. But it says, how would you suggest incorporating postnatal depression screening into postnatal follow-ups?
Right. Now, postnatal women, as a psychiatrist, I'm scared of them when they're depressed. I would not advise you to hold any woman that is postnatal and depressed on your caseload. It should be urgent emergency referral to the appropriate mental health center, either the perinatal services, and if they don't have opportunity to see the patient, emergency room ASAP. Get the husband involved and tell them to go to the emergency room straight away. The reason is this: I've had 2 incidents in my career, and they all relate to postnatal women. Both patients were seen. They said everything was fine, but they were depressed. The first one jumped from the high story with the child and died. The other one was seen in the emergency room, admitted. The next day, we told the doctor, everything is fine, I'm okay. Like I said, nothing has changed, but was saying everything is fine. Discharged home with virtual psychiatric inpatient unit for follow-up. Next day, husband found patient in the bath with a deep cut in the neck. So postnatal women, for me, based on my experience, I don't joke with them when they express suicidal ideation. Now, postnatal women will not tell you they are suicidal. They will tell you, I'm a bad mother. I do not deserve to have a child. The child does not deserve me. There's what is called infanticidal thoughts. So whenever you see a postnatal woman, it is important to ask about infanticidal ideation. Do you think you deserve this baby? Do you think this baby is better to be alive? Now, infanticidal thoughts in postnatal depression sometimes is the mother believing that the child will be, they want to help the child to exit the suffering of being alive. It's not that they had intention of killing the child, but their psychotic thoughts at that time is that it's better off for this child not to be alive so that the child will not suffer. So it's important. There's nothing wrong in asking, do you have any thoughts or belief that your child does not deserve to be alive? And we can I ask those direct questions. I'm not sure that's helped to answer the question.
Yeah, I think that's great. We're getting some nods. There's one. So what do you do when the patient has suicidal ideation and is refusing to go to the emergency room?
Maybe I'll ask a bit more. This patient of mine lives in Vancouver.
I just met him in the last 6 months. He was from childhood, but he's definitely quite depressed, doesn't leave the house much, hopeless. Yeah, it's just been, but he's missed the psychiatry appointments, missed appointments. He's adamant he doesn't have any intent or plan, but I mean, he says, like, if MAID was available for mental health, I would take it. So I don't know. Do I call the police? He's terrified to go to the hospital. It takes a lot for him to get to a mental health. He had a bad childhood experience. So I guess I feel I don't have enough to call the police. He's pretty adamant, but I mean, I've only seen him once in the last 10 years. He's in Vancouver. So I guess I'm just not totally sure. At this point, he says no, but I don't know in 2 weeks or, yeah, I guess I'm concerned about him. He worries me, but he is not accessing. He had an appointment September 3rd with psychiatrist. He didn't keep it. So I guess I'm asking your point of view.
Now, very valid question. And it's one of those things that, like Riley said, keeps primary physician awake when they are kind of low, medium risk. You don't think they need to be certified because the history is chronic. But what do you do? Now, key thing is this, like I said earlier on, if a patient is missing appointments with a specialist and they are expressing suicidal ideation, right? That in itself, because, one of the key things, if you look at it from 4.1, if I see the patient the next time, now I understand the fact that they had a bad experience with hospital.
Yeah.
And we want to work with them. Once I'm going to give two scenarios. One is that, okay, is there a safety plan? Does the patient have the capacity to work with a safety plan? If things are getting worse, can you call? Do you know what to do? And document clearly. Patient is aware of the safety plan.
Okay.
Now, this is the other side. This patient is missing appointment with specialists. Did he give a reason why they did not connect with the specialist? Because if they are missing appointment with specialists in itself, it's a red flag for me. So I'll be telling the patient, look, I'm going to give you another option to connect with services. I want you to connect with them. Now, if you don't, I may have no choice but to ask you to go to hospital for further assessment because I need a specialist involved in your care. I can't
Yeah.
manage you alone.
Yeah. So in this situation, sorry to bring up specific ones, he said he was vomiting. I had just started him on escitalopram and he said he vomited, he couldn't make it. And then something like, it's a bit vague, but the next appointment's mid-November. I think they tried to give him another one. He had a terrifying experience with hospitals and he's a bit afraid. He still keeps his appointments with me every month, but it is worrying me because he is feeling so hopeless. But yes, he had a little bit of what he tells me. But anyway, it just makes me knowing, yeah.
What you can do is that instead of monthly appointments, what you can do is to offer more frequent appointments.
Okay.
Right? Every week, because one of the things that CMPA will look at or medical legal will look at is that what action did you take? Right?
Okay.
So leaving someone who is not connecting with services on the monthly appointment, they said, but you haven't changed your practice with the patients.
Okay.
You haven't offered more like I said, the psychological intervention is very key and important. It can be 5 minutes check-in every week. There's a way it can instill hope.
Okay.
Right?
So if he's in Vancouver, obviously he's not coming in to see me. He doesn't have a car, that whole thing. I guess I'll do a weekly check-in. If he starts to miss, that's enough to phone the police and say,
Correct.
hey, okay.
Absolutely.
Right.
I will do that. I will call the police and say,
Okay.
please, this patient has been missing an appointment. It wasn't certifiable. It wasn't expressing any intention plans. And there's no harm in asking the patient, if things change and you start to have thoughts that you're going to act on, would you let me know? Or would you go to emergency room and document it?
Okay. Sounds good. Great.
Right? It's a safety plan.
Okay.
So the key thing here is there a safety plan?
Okay.
And the patient is agreeable to the safety plan. And then you document that, well, patient at the moment, I'm not sending the patient to hospital. So you have to give rationale, reason for your actions.
Okay.
Like rightly said, if you certify the patient and send the patient to hospital, that could be traumatizing for the patient. But
Yeah.
let's remember that when we give medication to patients, our medication, for example, Tylenol, can cause liver damage, but we prescribe it. We give it when the benefit outweighs the risk.
Mm-hmm.
So the key thing is this: hospital definitely can be traumatizing for the patient, but we weigh the benefit and the risk. Is going to hospital of more benefit to the patient compared to the risk of the trauma that the patient experienced? If the answer is, you know what, the benefit of you going to hospital outweighs the risk, then of course they go to hospital.
Okay. Yeah.
So that is the way I would judge it in terms of looking at it from a medication point of view. Like, all medications have side effects, but we still prescribe because the
Yeah.
benefit outweighs the risk. So the question is, does the benefit of going to hospital outweighs the risk? If it does, of course they go to hospital.
Got it. Great. Thank you.
No worries at all.
And excellent timing, 7 o'clock, and there's no more questions in the chat box.
Oh, awesome.
Was there any last minute hand raises or questions? No, perfect. Well, if any other questions come up, please feel free to email them to myself or to anyone at the Langley Mental Wellness Clinic's contact information, Jen or Mei Ling. Thank you, Dr. Lajitan, for this evening, and have a good night, or have a good rest of your night. Get your water wings on for your ride home.
Thank
Thanks
you.
so much, everyone, for joining. I appreciate it.
Thank you.
Okay, then. Bye-bye.
Bye.